Good morning everybody and welcome to today's National Organisation for Fetal Alcohol Spectrum Disorders Australia webinar. I'll now hand you over to Anne to begin.
Hello everyone, and yes, I'd like to welcome everybody to our seminar series for the remainder of 2016. It's wonderful to see so many people from across the country being able to tune into this presentation. Technology is just wonderful because we can connect from so many remote places, and I'm on the beautiful northwest coast of Tasmania. This may become very apparent if my roosters try to help me present, so I apologise in advance if they do. Hopefully you won't hear too much of them. And as Jeff said, if you have any questions, I'll try and answer as many of them as I can at the end of today. So just make a note in the chat box and we'll return to them, but many of your questions may be answered as we go along. So we'll get started. So a little about the National Organisation for Fetal Alcohol Spectrum Disorders. We were established in 1999 to represent the interests of people and families living with FASD in Australia. So we're the essential bridge between researchers, clinicians and those with lived experience. We're now the national peak body working towards influencing policymakers and medical professionals for the rights of individuals with FASD and the rights of their families. Our vision is the prevention of alcohol-exposed pregnancies in Australia and an improved quality of life for those living with FASD. This is the work that NOFASD Australia delivers. We have support services which are online and telephone inquiries and advocacy through consultation. We engage with the community by applying a community development approach because communities are unique and diverse, and this is where change happens within the community. We have policy and advocacy because we represent the interests of those living with recognised and unrecognised FASD. We provide education and training to the service provider sector. And because this is where most of the need is, unfortunately, some of the bigger barriers to understanding FASD as a brain-based condition. We develop partnerships because a small staff team means NOFASD Australia cannot meet all of the demand, and because we're positioned within the FASD problem system in Australia. And we do research because we must ensure that the research should inform and improve the lives of those who are living with FASD and those lives that will be affected as families as well. So this presentation will meet a number of objectives. By the end of the session, you should have a knowledge of what FASD is, how it affects the individual, the learning challenges faced by children growing up with FASD, the best ways that you can respond as an educator to a student or a child with FASD, how you can support them because responding to and offering support can quite often be very different and result in different outcomes. And finally, self-care for you as a person who is responsible for or a person who cares for a child with FASD. So what is fetal alcohol spectrum disorder and what causes it? So there are a number of conditions that can be caused by the developing fetus being exposed to alcohol. These can be both physical and neurodevelopmental, and FASD is a term we use to cover all of these possibilities. FASD is now one of the most serious harms caused by alcohol from the time the child is conceived right through to death. FASD can be prevented, but at the moment in Australia, it's the leading preventable cause of non-genetic disability. There are more FASD sufferers born each year than all sufferers of autism, spina bifida, cerebral palsy, Downs and sudden infant death syndrome altogether. And because it's so prevalent in Australia, this is a very serious public health issue. FASD does not discriminate in any way, so any woman who drinks alcohol during pregnancy at any time can put their unborn child at risk. FASD can be difficult for practitioners too to distinguish from the developmental disorders, since some others share similar learning and behavioural problems. As a result, FASD is often misdiagnosed, so the treatments and recommended strategies don't always work effectively. In the diagnosis process, it's really important to try and find a practitioner who's knowledgeable about FASD so that the correct diagnosis can be made. And NOFASD can assist you to find those practitioners if you don't know who they already are. Alcohol causes changes in the way that the brain develops, and this cannot be reversed. Often you'll hear how some organs can fix themselves with time and removal of a toxin. For example, we quite often hear that once you stop smoking, the body starts to repair itself. This is not the case with brain development because the damage has been done at the time the brain is forming. And at this stage, there is no evidence to indicate that the effects of prenatal alcohol exposure cannot be cured. An adult healthy liver can metabolise only about 1 standard drink of alcohol in 1 hour. So for the unformed or unhealthy liver, it can take much longer for the body to free itself of alcohol. So the alcohol needs to go somewhere else when it enters the growing fetus. This slide shows the risk to the developing fetus across gestation. The dark green area shows the highly sensitive period, and note the central nervous system is developing from the 3rd week of pregnancy, and the brain from the 20 to the 36th week of pregnancy. So you can only guess what may happen when alcohol is consumed prior to even confirmation of pregnancy, which may not be until the 5th or 6th week. In that time, the brain and central nervous system, the skeletal and major organs, the ears, the eyes, the teeth, the genitalia are all developing, and they may already be damaged if alcohol is consumed. And right up to the end, until the fetus is born, while it's still developing, alcohol can cause problems. Damage can occur to various regions of the brain. The areas that might be affected depend on which areas are developing at the time the alcohol is consumed. And here you can see the differences between the developing brain without alcohol and another brain at the same time that has been subject to alcohol. There's quite a lot of difference. And not all brain damage is seen on brain scans, as lesions might be too small to even be detected, but large enough to cause significant disabilities for the child. And this is an extreme example of what may be seen on scans where prenatal exposure has been significant. The safest way to avoid fetal alcohol spectrum disorders is simply to not drink alcohol when you are 1, planning a pregnancy, 2, during a pregnancy, and 3, when breastfeeding as well. Unfortunately, the first thing a mother is likely to do when they find out their child may have FASD is to blame themselves. But we know that no mother intentionally tries to harm their unborn child. So one of the worst things we can do is judge a mother if her child has FASD. FASD is the result of the lack of knowledge around drinking while pregnant. And if you're not planning to become pregnant, you may well be drinking in that vital few weeks when the central nervous system of the fetus is developing. The chances are increased if you enjoy a drink, have not heard of FASD, and then are surprised if you're pregnant. So we'll now look at what the medical diagnosis looks like. The guidelines are currently being updated, so some of this terminology is changing a little, but ultimately it's the same message. On the spectrum of fetal alcohol spectrum disorders, fetal alcohol syndrome is the full syndrome. FAS can be caused when alcohol is consumed by the mother on the 17th to the 20th day of pregnancy. And with FAS, there's very visible differences in the face of the child. There are also often physical abnormalities associated with FASD. These can affect school performance and achievement. For example, poor vision or hearing loss associated with malformed ears and eyes. There are multiple possible abnormalities, and in FAS these can be mostly identified in facial features. So we'll have a look at these now. In this picture, you can see that the child has small eyes. The area between the nose and the upper lip is smooth. This is called the philtrum. And a thin upper lip as well. You can also see in this picture that FAS children have a flat midface. Across the cheeks and nose area is flat. A small head circumference, which is the measurements around the head. Low set ears, so the ears are lower on each side than normal. And sometimes a small chin or the fingers and hands may have some malformation as well. This example outlines more detail about the eye. A FAS child will have smaller than average distance between sections A and B. It's also possible that there'll be a flap between the nose and the corner of the eye, which is visible in this picture. And you can see a scale of lips on the right-hand side that's similar to the ones used in diagnosis, whereas 1 is no presence of FAS and 5 indicates a definite presence of FAS. On the spectrum of FASD, there are also 2 other diagnoses that are not as obvious as FAS, but just as severe. These are partial fetal alcohol syndrome, which has some physical signs of FAS, but not all of them, and neurodevelopmental disorder, alcohol exposed, where there are no physical signs, but there has been prenatal exposure to alcohol. All diagnoses of FASD include impairment in the central nervous system. Those that have neurodevelopmental disorder, alcohol exposed, are at the highest risk of misdiagnosis because they do not have the physical features. This is often put down to the child's behaviour rather than a disability, which is why so often FASD is called the invisible disability. But unfortunately, there is absolutely no difference on how severe the dysfunction in the brain is. These diagnoses have different criteria, but all are the same in that there has been some kind of damage to the brain. What the damage looks like will be different from child to child or person to person, and each one will have different challenges in daily living, learning, and how they behave and respond. So what are the signs that a child or a student that you're working with may be living with FASD? Firstly, FASD children grow different to others. They're usually slower in growth and smaller overall. And that may be one of the things that people will notice first. And with that, there is likely to be other physical abnormalities, as we've talked about. And you may also notice that the child has difficulty seeing or hearing. They may talk later than other children of the same age, or have problems understanding what they're being told. And they'll struggle with writing problems and with reading and problem solving. The child may also be too trusting towards others, which can lead to negative situations and scapegoating. The child will not be able to concentrate for very long on any one activity, and they're highly active and impulsive. And this may result in having poor relationships with others, which causes them to become socially isolated in their peer group, so often preferring to play with younger children. And this is because one of the challenges of living with FASD is that the individual functions at a much lower age. So a 25-year-old may still be functioning as a 15-year-old, so we'll prefer to spend time with 15-year-olds. And to others, it will look like the child is distracted or confused, so not following instructions, irritated, impulsive, or throwing tantrums, repeating the same mistakes over and over again. They may engage in risky behaviour because they don't recognise danger, and being unsure of what's fantasy and what's actually reality. And they'll follow their peers into both good and bad decisions. And here's an example of what that may look like to a teacher. So your typical 5-year-old will go to school and follow 3, maybe 4 instructions. They'll sit down for about 15 minutes and they'll play and take turns. A 5-year-old with FASD will need to have a nap. They'll follow 1 instruction, but probably only if they're shown. They'll sit for 5 minutes and engage in parallel play, and they'll want their own way. They'll act like a 2 or 3-year-old. And again, a typical 10-year-old will stay focused for about an hour. They'll read and write fluently and be able to learn from worksheets. They'll play at recess and get along well with others and not tire easily. But a 10-year-old with FASD will act more like a typical 5-year-old. They'll pay attention for about 15 minutes. They're still learning to read and write. They'll still learn by doing and experiencing. They get overwhelmed really easily and tired easy. The most common impact of FASD is on the executive function of the brain. Executive functions are being able to plan, learn from experience, and have impulse control. The part of the brain responsible for executive functions is the prefrontal cortex, which is in the front near the forehead. This part of the brain may form poorly with FASD. And how are students affected with FASD? Well, they can be affected in many ways. These can include visual and auditory processing problems, difficulty with reading and comprehension, memory problems, sensitivity to sensory input, and attention deficits. And the list goes on. Problems with social behaviour, problems following multiple directions or rules, particular difficulty with numeracy and abstract reasoning, inability to understand cause and effect, and difficulty organising tasks and materials. As a result of auditory processing problems or hearing problems, FASD students may struggle particularly with maths. They'll have a difficulty responding to traditional teaching methods, so they may fidget or become frustrated. If they don't know what's going on, they're likely to have a meltdown. And unfortunately, a meltdown will most likely be punished by the teacher or caregiver if they're not aware of FASD. But the child will also be unlikely to respond to traditional punishment methods. So in a sense, they're actually getting punished for not being able to understand. And this is not the disruptive behaviour of a naughty child, it's one that is unable to process. But you may be able to recognise when someone with FASD is feeling overwhelmed. And when they do feel overwhelmed and it results in a meltdown, you may be able to see this happening, and here are some strategies that you can use. Is be sure everyone is safe and that the child is in a calm space. Slow down if you're talking or doing something too fast, and don't use many words, don't use a great number of words. So back off, and sometimes you may feel that it's okay to walk away and let them self-calm. Don't shout or use no's and don'ts. Try to find a yes. And these can be the best ways you can show support until you can talk it out. So, how can we help students with FASD? And there are a number of ways. These include ensuring that the curriculum is appropriately modified and that the approach is concrete and consistent, and that you persist with it and include a lot of repetition. Keep to a good routine and make it simple and specific. Now, these kids are younger than they are. As I mentioned earlier, a 15-year-old may developmentally only be 8 or 10. Always think younger when planning curriculum or expectations around behaviour. All of the modifications that you make should be planned around where the student seems to be at developmentally, not chronologically where their age is. So think concrete and think younger. Don't use anything that may have a double meaning, like this will be a piece of cake for you. Because the child probably won't understand that. They'll be thinking about cake, or they probably won't be expecting that the task is easy as it's implied. Be specific. This task will be easy. Always be consistent. In a school, this will mean communicating with other teachers, parents and caregivers who are also involved working with the child. So everybody can use similar language, for example. So you may want the child to do the same thing in the same situation, but if they've learned two different ways or haven't learned the boundaries, they will struggle. So if a young child has learned to remove their shoes as soon as they get to the classroom, it's unlikely they will do the same elsewhere unless they're consistently taught to do this and in the same way. We're aware of rote learning, being taught the same thing over and over again. This works with children with FASD because it moves the information from the short-term memory into the long-term memory. And because FASD children have problems with short-term memory, they're unlikely to remember something unless it's repeated several times. And then there's a much higher chance that that information will move into the long-term memory. So using the shoes example, a FASD child will need to be told a number of times when they arrive at the classroom to take their shoes off before they enter. They will be unlikely to learn this the first time and remember it. And this repetition starts a routine. So if you're able to stick to a routine at school and at home, the child will know the same things are expected of them each time. And this reduces the anxiety, so it'll help them to learn if they're less anxious. Short and sweet is always the best way to help a child with FASD learn the ropes. Too much information in one go can cause confusion and shut down for the child. So try to keep the environment free from any unnecessary stimulation and give one instruction at a time. So don't say something like, come in, sit down, open your book up and start reading. Give the instructions one at a time after the first one is complete. So once they've come into the room, then tell them to sit down. Once they've sat down, ask them to open their book up. Once they've got their book out of their bag, ask them to start reading. FASD children respond much better to working in simple one-to-one situations and small group situations. As I mentioned before, don't talk with double meanings. If you want the child to do a task, tell them exactly what you want them to do, step by step. And if you can, also show them. Use as many visual aids as you can, like charts and pictures, and that'll assist both you and the child. So all of this creates structure. If you're concrete and consistent, if you persist and include repetition, if you keep to a routine, make it simple and specific, you will have created an environment with very good foundations. This applies to all areas of life for a child with FASD. And always remember that because a child with FASD can be naive and gullible, they can often become the scapegoat. So to develop appropriate behavioural patterns at school, they need to be consistently supervised so that they're not led astray or encouraged into inappropriate behaviours. When something doesn't seem to work, stop and have a look at what's going on. And always ask them what would help them to calm down. Maybe they need some rest time. Maybe they need some more information to complete the task. Always remember that they're trying to make the right choices and offer encouragement when they do make the right choice. And as I said earlier on, each child will be different depending on the areas of the brain that's been damaged. There is not a one-size-fits-all approach with FASD children. It's a trial and error approach that will need modification from time to time and from student to student. With FASD children, it's more likely that they can't do something, not that they won't. And remembering this takes practice because it's thinking differently and in some cases working very differently. Quite often the primary condition of FASD is that the brain injury can be misdiagnosed. And those living with FASD can suffer many difficulties because of frustration or sadness of not being understood. And there's a real fear for the child as a growing adult that they do not live up to the expectations of others. And this can lead to a number of associated problems, and they're called secondary conditions or secondary disabilities. And these are the kinds of things that can result. Just some examples include using illegal drugs or relying on alcohol as they get into their teenage years, depression and anxiety, dropping out of school or being suspended from behaviour, and breaking the law. It's also withdrawal and avoidance, early parenthood because of inappropriate or early sexual behaviour, multiple mental health issues, anger and aggression, and these can all lead to poverty and homelessness. With the right supports, the quality of life and the quality of education for those living with FASD can be significantly improved. As with any disability, and as you've seen today, there are so many things we can do to ensure the quality of education is the best we can possibly provide. Similar to autism, a person living with FASD is likely to be extremely good at something, far more than you would expect, whether it be creativity, athletics, music. It's vital as an educator that you recognise their strengths, nurture them and develop them. Unfortunately, these can also mask the severity of other symptoms though, so be aware that if someone is incredibly artistic, they may also be avoiding possible contact with other students or engrossing themselves into something so they can withdraw from other areas. So even though these may be extreme strengths, if we're going to nurture them, we also need to keep these in mind so we can support and nurture the strengths. A child with FASD will have difficulty understanding the consequences for their actions. They'll have developmental delays because of a short-term memory. They'll struggle with setting goals and staying on track. They'll need to rehearse and then rehearse again. And when you're working with someone with FASD, ask them to paraphrase, ask them to repeat back to you what you've explained to them so you know that they've understood and heard what you've said. Be creative, as I mentioned, you use as many visual tools as you can and other props to tell a story. And keep it as simple as you can. And some more tips. Ensure that the learning is as relevant as it can be. Focus on the strengths and encourage, praise when something's working well. Try to accommodate and use other environments where you can or where you need to. Keep in touch with the parents and other teachers that you're working with. Avoid excessive homework or long assignments. And help as much as you can with their study. Something to be aware of in the environment of the school is social exclusion. This can be a huge challenge for children with FASD. Because they're developmentally delayed, they'll struggle with socially acceptable behaviours. They seem and they are developmentally younger than their peers in the same class. And as I mentioned before, they can become the scapegoat and they can be bullied and teased. They may not understand social etiquette. And they won't understand the subtleties of different kinds of relationships that we have. But it's always important to keep in mind that they can't do something. It's not that they're naughty and they won't. So be realistic what you expect from these children and try to accommodate their social and environmental barriers. So to summarise this section, always remember it's important that it's not always that they're naughty. They may actually be using survival skills. And remember to look after yourself too. It can be quite intense working with a child that has FASD, and you need to acknowledge that the experience will probably affect you as well. So be honest with yourself that working with a child with FASD will be challenging. And a few things that you can do is talk to someone you trust. You could have someone in the school that you can talk to, or family. A lot of people have clinical supervision. Do things that you enjoy, like exercise or massage or yoga or music. And you can also contact us as well for support. We're here to help, so finally we can help you develop a plan to be able to absorb the emotions of it all. We listen and offer support. And we can take away some of that emotional pain. Our website is loaded with resources, and there's still something that you can't find, get in touch with us. Or if you'd just like to talk to someone, you can also call us as well. These are our details. So to follow up on today, if there's any information that you would like, or any details, or want to know when training's being undertaken, please feel free to contact us at any time. So that brings us to a close of today's webinar. We'll also be running another webinar on the 9th of September at 9 AM, so stay tuned into our website for details on how to register for that. And now I will have a look at a couple of the questions. A couple of people have asked if the slides can become available, and yes, this presentation will be emailed out to people as well, which I believe will include the slides. Again, if there's something that you would like that you don't receive in that email, just get in touch with us as well. There's a question here from Jennifer about how a child, a 10-year-old, prefers to play with younger children. Do we think keeping a child down for a year would help to be with younger children, or do you think it would impact too much on social skills? That would be more a question, I think, for people working with the child at the school. They would be able to advise best on where things are working and where they aren't. So I'd refer you back to your school and people working with the child, Jennifer. And Nancy has asked, when assessed, do FASD children have an intellectual disability? The answer for that is yes, they do have an intellectual disability, but FASD is not recognised as an intellectual disability. So it is usually some of those secondary disabilities that the child can use to help assist and gain an intellectual disability status, particularly in terms of the NIDS programs. And I think that covers the other questions as well. So if anybody would like to get in touch with any other questions, please contact us on the screen. Otherwise, we will leave it there for today. Thank you everybody for attending, and I hope you will join us again for our next webinar next month. Take care.